Hello, my name is Professor Charles Kingsland and I'm the Chief Medical Officer at Fertility. We spend most of our young adult life trying to prevent pregnancy. We receive contraceptive advice in school, which we leave often thinking that getting pregnant and having a family is the easiest thing in the world. To many couples it is, but to an increasing number, infertility, the inability to start a family at a time in your life when you want, is becoming more and more common. In fact, it's one of the most common conditions we are now seeing in hospitals and clinics, where as many as 1 in 6 couples, yes 1 in 6, experience fertility issues. There are numerous reasons why the incidence of infertility is increasing, and I will briefly summarise these. Some of them may surprise you. Firstly, although our general health and nutrition is much better than it was, say, 100 years ago, we are getting fatter as a population, and this is not generally good for our fertility. Overweight people are less fertile than those of normal weight. Of course, we all know overweight and even obese people who have lots of children. There is no doubt that their fertility would be even higher if they manage their weight. We measure our weight as our body mass index, or BMI. This is your weight in kilograms divided by your height in meters squared. For ideal fertility, your BMI should be in the range of 20 to 25. Secondly, the typical male sperm count has dropped by as much as 50% in the past generation, probably making us males less fertile than we were a couple of generations ago. There are a number of possible causes for this. Again, diet being one. Atmospheric pollution may be another. Toxins to sperm such as nicotine, excess alcohol and anabolic steroids, often taken by those who use the gym often. These can have a devastating effect on sperm quality. Thirdly, the incidence of sexually transmitted diseases is on the increase, particularly an infection called chlamydia, which can have an effect on a female's reproductive function by causing obstruction or even blockage to her fallopian tubes. These are where the eggs and sperm are supposed to meet. Sadly, some diseases like chlamydia can be transmitted from one individual to another without them knowing, and by the time you've got it, it's probably too late. So choose your partners very carefully. Finally, and most commonly, we are delaying starting a family for lots and lots of reasons. Just 100 years ago, which is not long in our evolutionary history, because after all, we've been knocking around on planet Earth for about 40,000 years, a woman was on average 20 years old when she had her first baby. Last year in Great Britain, the average age of a woman having her first child was 31 years old. Now, this may be a good thing on many levels, but one thing that hasn't changed is a woman is born with all of her eggs, and they grow old with her. There is absolutely nothing you can do to make your eggs younger, irrespective of what some people may tell you. As your eggs get older, your fertility declines quite rapidly over the age of 35. And after that, fertility really drops like a stone over the age of 40. This is slightly different for males who have all the ingredients in their testicles to make sperm. They are sperm factories as opposed to egg warehouses in the case of women's ovaries. Although men's sperm making ability declines with age, this is usually a slower process. At Fertility, we believe that family is for everyone. Whether you are in a heterosexual or same-sex relationship, or indeed, if you're not in a relationship at all, your company has partnered with Care because they prioritise inclusivity and the well-being of their staff. There are many things you can do to protect your fertility before you want to start a family. But if you are ready to start and you're worried, or you'll find yourself in difficulty, there are lots of things that we can do to help. Whether it's just simple reassurance, basic testing, or if we feel you need some form of treatment, we're here to help you. Here are some of the basic rules to optimize your fertility, and they are basic but important. Eat and sleep well. Avoid nicotine and too much alcohol. If you are thinking about trying for a baby, take folic acid. There is no doubt that it helps to build healthy babies. Keep a track of your menstrual cycle. This will give you a good indication of the length of your cycle and when you can work out when you might be ovulating or releasing an egg. There are apps which can help. Try and reach your ideal body mass. Easier said than done, but do your best. Exercise regularly, but don't go mad. And don't take supplements. If you're in a heterosexual relationship, have intercourse regularly, 2 or 3 times a week should do it. If you're in a same-sex relationship, make sure you inseminate at a time of ovulation. You can test for this and we can advise you. Sperm like being produced in the cool, hence testicles hang outside the body. Keep them cool. Wear boxer shorts, avoid hot baths and avoid heating the testicles up. We're all stressed, and whilst it's not necessarily bad for us, try and avoid too much stress, particularly when you're trying for a family. This could be stressful enough, and some things to watch out for. There are lots and lots of products on the market that claim to enhance your fertility. The vast majority do not. But as long as they're not harmful and you're properly informed as to their relative benefit, we are all free to spend money on what we like. There are lots of things we do in medicine that are of doubtful significance, but if we are paying for that treatment, advice and treatment comes into sharper focus. And it's a sad and frustrating fact of life that although infertility is a very high-profile illness, it comes very low on the list of NHS priorities. That's why many treatments are not available within the confines of the NHS, and you have to fund them yourself. That's why, if the time comes for advice, you need the very best advice. If in doubt, get advice from a qualified fertility doctor or nurse if you've not become pregnant within a year of regular, unprotected sex. Then you should speak with a fertility specialist. It may be shorter if you're particularly worried. When you are thinking about fertility treatment, there's a lot to consider. The cause of your fertility issue, what treatment options are available, and what is the actual process of IVF. While everyone's treatment is personalised for their needs, the stages of the treatment journey are usually similar. Before your first consultation, you will have some pre-treatment tests. These tests include pelvic ultrasound to assess the uterus and the ovaries, and you will have a blood test to check for a hormone called AMH to give us an indication about the store of eggs in your ovaries. This is called ovarian reserve assessment. For male patients, a semen analysis gives important information about the quantity and quality of the sperm. For anyone in a same-sex relationship who may be unsure which partner or both will have treatment, we would suggest that both partners have these initial investigations. At your first consultation, your doctor will review your medical history and all your test results and explain them to you. If you've had fertility treatment in the past, this will again be discussed in detail. Treatment plans are always personalised and can be very simple, such as medication to boost ovulation, or more complex like IVF. Around 40% of fertility issues are sperm related, and there are additional techniques which are designed to address those challenges. We try to give patients an understanding of their potential personal success rate and what to expect from treatment. We often find that after the consultation, people may think of additional questions they want to ask, or they may have something they want to clarify. At Care, we have a patient team called Care Pals who are available to contact following your consultation to guide and advise on next steps and answer any questions. Before you start treatment, there will be education modules and treatment consent forms to complete. The next stage is the beginning of treatment. The first phase begins with a fertility drug, which is a hormone injection to stimulate your ovaries to develop the eggs which will be used for your treatment. We monitor you while you're having these injections with serial ultrasound scans to measure the response and to establish the best time for your eggs to be collected. We will then advise you when it is the right time to take what we call the trigger injection. This very last injection is called an HCG trigger, and it allows your eggs to complete their final maturation before egg collection. This is the next stage of your treatment, the egg collection. This is usually planned 36 hours after you have taken the final trigger injection. You will always be given clear instructions about the date and time of your egg collection and when you are expected to be admitted to the ward for the procedure. On the day of egg collection, when you're in the clinic, you'll be welcomed and admitted by one of the nursing team to the ward, and they will prepare you for your egg collection. Your egg collection will be done under sedation. The egg collection procedure itself is relatively simple and straightforward and is carried out transvaginally. It takes about 10 to 20 minutes, and at the end of it, we hope to have collected 80% of the eggs that are mature. Once your egg collection is complete, you'll be taken to the recovery bay in the ward, and your nurse will look after you and make sure you're comfortable and pain-free. You'll be usually given something to eat and drink so that you are nice and comfortable before you go home. If your partner is providing sperm, or if you're using donor sperm, that will be thawed on the day, and the sperm sample will be analysed to check suitability for treatment. The embryology team will call you and update you to confirm the number of eggs collected and that the sperm sample is suitable to go ahead with treatment as planned. Once you've gone home, we will continue to stay in touch with you. One of our embryology team will update you on how your embryos are developing and give you time and a date for your embryo transfer, which is commonly on day 5 after your egg collection. Following egg collection, the eggs will be put into a special culture medium and safely transferred to an incubator to provide exactly the right environment and temperature conditions. We spin the semen sample in a special media to isolate the dense, good quality sperm. We then wash the isolated sperm in another media to purify the sample. Next, we fertilise the eggs with the sperm to form embryos. We then grow the embryos in carefully controlled conditions until they're ready to be transferred into your womb. The first signs of fertilisation are shown by the presence of 2 nuclei within the egg. If this has occurred, the fertilised egg should then divide into 2 and subsequently 4, 8 or even more cells in the embryo. At this stage, a nurse or an embryologist will arrange a time to give you your fertilisation result and also a date for your embryo transfer. This is the most important step in your treatment, the day of your embryo transfer. The embryologist will give you a date and a time for you to arrive in the clinic, and when you arrive, you will be admitted to the ward by the nurse and given a final update on the status of your embryo by the embryology team. The embryo transfer procedure is very straightforward. It is almost always performed without the need for sedation. Your specialist doing the transfer will carry out the procedure in theatre, and we use a speculum just like when you have a smear test, and the embryo is transferred into the uterus using a very soft catheter under ultrasound guidance. The procedure should not cause any discomfort and only takes around 15 minutes. You'll be able to go home whenever you're ready. During the period after embryo transfer, it's important to take the hormone progesterone. This helps prepare the lining of the womb for the implanting embryo. It's important that the progesterone is taken until the first pregnancy test. This period is often referred to as the 2-week wait. It can be challenging and it can seem like forever to pass because, of course, you're anxious to learn the result of your treatment. Try to stay positive. You've done everything you can. And if it helps, you could speak to others at the same time or at the same stage of their IVF treatment on one of the fertility forums. CARE has a forum with a section called the 2-week waiting room. Remember, you're not alone. Your clinic team understand that the 2-week wait can be an extremely anxious time, and they can support you. Around 14 to 16 days after your embryo transfer, you will take a pregnancy test. If your pregnancy test is negative, or we don't find an ongoing pregnancy during your scan, we know that you'll feel upset. Support is always available to you. You may find comfort in speaking with a specialist fertility counsellor who can help you to understand the process and the emotions that you may be feeling. When you feel ready, you can arrange a follow-up appointment with your consultant to discuss your next steps. If your test is positive, we'll invite you to come into the clinic 2 to 4 weeks later for an ultrasound scan to check for a heartbeat to show an ongoing pregnancy. Once this is confirmed, you'll be discharged into the care of your GP, who will arrange your antenatal care. Alison, our Chief Scientific Officer, is now going to explain what we can do to help if simple advice fails to do the trick.
Hi, I'm Alison Campbell. I'm Care Fertility's Chief Scientific Officer. Our ethos has always been to continuously generate ideas for improvement, explore scientific potential, remove boundaries and develop new techniques. Why is this so important to us? Well, we've demonstrated that by doing this, we can develop and perfect treatments which help more people and improve success. Most people undergoing IVF fertility treatment have a number of embryos, and it's really important that we choose the best one to transfer to the patient. One example of how we have innovated in this area is the development of Care Maps. Care was the first in the UK to introduce time-lapse imaging of embryos. And about 10 years ago, using this technology, we developed and published a new method to classify embryos in a way that had never been done before. This discovery made the news internationally. We've continued this important work, and very recently we've introduced artificial intelligence to improve embryo selection. We built this novel technology after analysing almost 500 million images of embryos. There are many examples of how our experts undertake research and innovation. And as a result, we've developed a great toolkit of treatments, and we see the benefit of this in success rates for our patients. Artificial intelligence is being introduced into many aspects of our lives, from speech and handwriting recognition to gaming and healthcare. It's been demonstrated that artificial intelligence, and specifically machine learning, can outperform humans in many human decision-making tasks. Humans make decisions based on their experience and often very simple rules. In IVF, scientists and medics make many decisions. One of the most critical ones to treatment success is which embryo to choose. Care fertility scientists have undertaken extensive research over a decade to improve the accuracy of embryo selection. And this resulted in models or algorithms called Care Maps to select embryos with the highest chance of becoming a baby. Care's work in this area has been widely published. And our latest development uses machine learning to analyse embryo development right from fertilisation up to the point of embryo transfer to the patient. Because we have a large group of clinics performing the same high-tech embryology, we collated almost 500 million images from 63,000 embryos from our time-lapse incubators and trained a machine learning model to assess their development accurately and automatically. Our own research, which has been presented at the American Society for Reproductive Medicine conference, demonstrates how without such sophisticated tools, embryologists don't always agree regarding which embryo to choose. 57 experienced embryologists assessed single images of 240 embryos, and the embryologists' assessments agreed on which was the best embryo less than half of the time, despite them having undertaken the same training and education. Embryo assessment using machine learning, when trained on large, high-quality data, is more accurate and consistent than the assessments made by humans. Machine learning assessment is consistent. Humans change their minds. And it's estimated that an embryologist with 10 years training and experience may have gained experience from assessing about 10,000 embryos over that decade. And CareMaps AI was trained on 63,000 embryos and almost 500 million images of them. Accuracy was assessed using previously unseen embryos by comparing the results of the machine learning model with human assessment of embryo development. This research was recently selected and presented at the European Society for Human Reproduction, the ESHRE conference. The machine learning model, CareMaps AI, automatically and rapidly generates assessments of the embryos. We compared how reliably this information could be used to predict which embryo would make a baby and how it compared to existing manual methods. And CareMaps AI resulted in more accurate predictions. So this is really exciting and a big step forward for more automated embryo selection. This technology is safe and non-invasive. It assesses images of embryos which are already being collected, and the machine learning model was trained on our own extensive high-quality data. There's increasing evidence supporting the application of machine learning to utilise big data from time-lapse imaging and fertility care generally, and this is great news for fertility patients.